Diabetes is a really big topic, and so we've broken it up into 3 different lectures. In this lecture, what we're going to cover is screening and diagnosis primarily, and then some of the stuff you do as an outpatient in order to manage it. We're going to go through some of the oral medications, the goals, and then the screening you need to do. In the subsequent lectures, we'll talk about insulin management, both inpatient and out. And the 3rd lecture will be those diabetic emergencies. So let's get started talking about who and how to screen. All right, this is very important. We haven't talked about the physiology of diabetes yet, but there's 2 types, type 1 and type 2. I want you to think of type 1 not as juvenile and not as needs insulin, because there are type 2 who need insulin and there are adults who develop type 1. Type 1 is autoimmune destruction of the pancreas. You won't screen these people, they will present to you. When screening and diagnosis is said, we're talking about the type 2s, the people who are slowly developing into diabetes, those who have insulin resistance from their obesity. Those are the people we need to screen early, because the earlier we find them, the earlier we treat them, the less micro and macrovascular complications you'll have from diabetes. So who do you screen? You screen those people who are at risk for getting diabetes. It's basically those with cardiovascular risk factors. Those who are 45 years old or older, people with a BMI greater than 25, and those with hypertension. So old people, fat people, those with hypertension, basically everybody. The problem is it changes depending on who you ask. And since screening for diabetes is really easy, unless you're super healthy, you should be screened for diabetes. That's basically what it comes down to. And there are many screening modalities, and you have to know how to interpret each one. One is definitely better than the rest, but each of them have their own utility and their own limitations. And you, preparing for the test, will have to interpret one of them. And so you have to know them all. All right, how do you screen? The first way is to get a random blood glucose. And what you want to learn is 200. If it's greater than or equal to 200, you've been diagnosed with diabetes. If it's less than 200, you have no idea. And you need one random blood glucose greater than 200 with symptoms of diabetes to make the diagnosis. This is how you screen people with type 1. They come in with polyuria and polydipsia, you check a blood sugar and it's really high, okay, you've got diabetes. The better way to do this is to get a fasting. And a fasting blood sugar needs to be obtained twice for confirmation. The numbers you want to learn for fasting are 100 and 125. Greater than or equal to 125 is diabetes. Less than 100 is normal. No diabetes. But between 100 and 125 is insulin insensitivity, now called prediabetes. And if you have prediabetes, you're not sure this person's a diabetic, then you can reflex to the next test, which is the 2-hour oral glucose tolerance test. You only have to do this once. This is simulating a postprandial glucose. You are simulating what actually happens to a diabetic. They eat something, their insulin should go up as their sugar goes up, and the glucose should be kept normal. But if someone is diabetic, when you give them that glucose load, they won't be able to control the sugar. What you're looking for here, the numbers you want to remember, are 140 and 200. Greater than or equal to 200 is diabetes. Less than 140 is normal. And in between 140 to 200, insulin insensitivity or prediabetes. Let's talk about these. So the 2-hour glucose tolerance test is good in the way that it is confirmatory, right? You get both the fasting You check their sugar before you give them the glucose load, then you give them a 75-gram glucose load, and you check their sugar 2 hours later. You'll have both a fasting and a postprandial. You're mimicking what actually happens in real life. You'll catch people with diabetes. But it takes 2 hours to do, and so it's time intensive. The fasting blood glucose is good, but you need a confirmatory test, and the patient has to be fasting. That's not such a big deal, but it's something to consider. And then the random blood glucose is probably the worst. It's good when you have symptoms, but you can't know what's going on in the patient's life when they check that sugar. And the random and fasting and even the 2-hour glucose tolerance test are all impacted by things other than diabetes. If they're infected or on steroids or whatever, if there's something that disrupts the glucose, you're not going to catch that, right? You're just going to see what's happening to them right now, which is why for most patients, the preferred method greater than or equal to 6.5 is diabetes, and in between, prediabetes. So why is this the best test? Well, the A1C, what it does is it measures the average blood sugar over the past 3 months. It measures glycosylation end products. It's based on how much red blood cells are around and how much sugar is floating around that gets stuck to the red blood cells. And since you can measure 90 days back as an average, you capture what's actually happening all the time, preprandial, postprandially, if they were on steroids and they came off. If their A1C is elevated, you can be reasonably assured that they are indeed diabetic. Now, there's some limitations to the A1C because it's a hemoglobin A1C. Hemoglobinopathies may impact the level, and it does not detect early glucose changes. That is, if someone is worsening right now on their way to diabetes, the A1C will miss it. Especially true in the setting of gestational diabetes, where it takes 3 months to get the A1C to rise, but all the while, baby is seeing that increased glucose. So the A1C is useful for the fat old hypertensive that you're screening, but not necessarily for everybody. But you should be using the A1C to screen people for diabetes. Greater than 6.5 is diabetes, less than 5.7 is normal, in between, prediabetes. There's also a consideration you need to have for type 1s. The patient is going to present to you with polydipsia and polyuria, and their blood sugar is going to be very high. Right? You're not going to miss this. Remember, type 1, no longer juvenile, no longer insulin dependent. Type 1 means autoimmune destruction. So if you see a kid with polydipsia, polyuria, weight loss, and a very high blood sugar, they've got diabetes. If you see the 65-year-old who had no diabetes, whose blood work was normal last year, who has polyuria, polydipsia, and a very high blood glucose, that's the same thing. That's the same autoimmune destruction of the pancreas. So it is appropriate when you see that rapidly progressive diabetes to get antibodies. If you see GAD or IA2, either one is correct. GAD is the better one. You do want to get the antibodies because if they're antibody positive, they have autoimmune destruction of the pancreas, and oral medications won't work. Doesn't matter how old they are. You're going to need to treat them with insulin. All right. Now, if they're not type 1, right, they're antibody negative, and you don't test for the antibodies, the answer is lifestyle and metformin. Eat better, exercise, lose weight, and start metformin. Medication is indicated at the onset of prediabetes. Both of these things have been shown to prevent progression of diabetes. You reverse the A1C, you get it back down below 5.7. So even if they're in the pre-diabetic range, you're going to treat with lifestyle and the medication. If they're not pre-diabetic and they're not type 1, they're just diabetes, how do you treat them? Now, the first step is going to be lifestyle and metformin. You saw that coming just on prediabetes. And then you come back in 3 months and you recheck the A1C. If they're not at goal, we'll get to what that is in a minute. If they're not at goal, you do something else. The second step is to add a second agent. Have them come back in 3 months, reassess the A1C. If they're not at goal, add insulin. And this is important to recognize. Metformin, it can induce a lactic acidosis. If you can use metformin, use it. The second agent is anything. It used to be very clear what we would use next, but now the ADA basically says, pick whatever you want based on patient preference and comorbidities. It's really tough then as a student to learn, well, what the hell do I use? And why would I use one over the other? There's no good evidence saying one is better than another, so we're going to have to talk about all the different classes so at least you recognize what they are and their side effect profile. And also notice that after 2 oral agents, failure to control the glucose means insulin. 3, 4, and 5 orals don't work. In fact, the hemoglobin A1C with oral medications will fall by about a maximum of 3%. And the hemoglobin A1C with insulins will fall about 7%. Now you can get a major change on the A1C, but you're going to have to do more than just insulin if you're going to get their A1C down to goal. If they need to move more than 7 points, they're also going to need to do something else like major diet and exercise, lifestyle changes. Which means that if your A1C is greater than 9%, you're going to start at insulin. Okay, let's just summarize that. Everybody comes in who has diabetes, lifestyle metformin, unless you can't. Then you add on another agent. That doesn't work, add insulin. We'll talk about insulin in the next lecture. The wild card is if their A1C in presentation is greater than 9, jump right to insulin because oral agents aren't going to get them to goal. Okay. Add a second agent. What are the agents? What are the classes? And how do you pick? All right. So we've got biguanides. That's metformin. Its side effect is diarrhea. And generally, if you can get through the diarrhea, sulfonylureas used to be the second medication to use. This is glipizide and glyburide. For you, not studying for the test, but for practicing medicine, should stick with metformin and sulfonylureas. They've been around a long time. We know their side effect profile, and they're very cheap. Keeps the cost of healthcare down. But the ADA says that none is better than the other, so you can use any of these. Sulfonylureas are going to actually increase the expression of insulin. It's like giving insulin. We're going to talk about this in the hypoglycemia talk in the 3rd diabetes lecture. If you're on a sulfonylurea, you can cause hypoglycemia. So use caution in CKD patients because insulin is cleared by the kidneys. Still safe to use, just recognize that hypoglycemia may happen. The TZDs, and I call them TCDs because their real name is too long and no one can pronounce it, are the glitazones. They increase insulin sensitivity, but they can or maybe cause CHF. Essentially, you're never going to use these because they also cause weight gain. And there was a 1-800-BAD-DRUG, which basically took one of these off the market, and so now people are scared to use them. They're still safe to use, just recognize they cause weight gain, and there's that risk of CHF. The DDP4s inhibitors, this is a carbose. It blocks intestinal absorption of the sugar, and if you do that, you're going to get terrible diarrhea and foul-smelling flatulence. So most people aren't going to want to use those. And then the SGLT2 inhibitors, the gliflozins, these cause euglycemic DKA. Stay away from these because they cause DKA. Their mechanism of action is the same mechanism of action that causes dehydration and leads to DKA. The alpha glucosidase inhibitors, acarbose, cause diarrhea and gas, and no one's going to want to use those. So really what you want to pick from is the metformin. Always use it, unless you can't. Sulfonylureas, be careful of hypoglycemia. And then pick one of the TZDs, DDP4s, or the GLP-1s. GLP-1s are injectables. They cause weight loss. DDP4s are weight neutral. And the TZDs cause weight gain. It's more complex than this, but I'm breaking it down into like the simplistic form as possible in order to help you memorize everything. And this is really important. Memorizing all this stuff is going to take a lot of effort. And in your notes are the list of medication names, more classes and mechanism of actions, and it may just not be worth the squeeze. In the way that you could study a lot and a long time on just that chart, and you may not even get asked a question on it. So if you have the bandwidth to memorize it, go for it. But otherwise, skip it, and if you have to take a hit on the test, do so, because there's a lot about diabetes you have to learn, and this is just one section. Right. We'll finish off with what you do in the clinic, seeing patients who have diabetes. They kept saying, are you at goal, are you at goal, are you at goal? Well, one thing you want to do is an A1C every 3 months. And the goal is less than 7%. And that's not totally true. Older patients who are going to die soon anyway may not need that tight control. People who are doing really well without hypoglycemia could go even better control. But what I want you to learn is the goal is 7%. Basically, all comers can be satisfied by that. You'll be thinking, hang on. Normal is less than 5.7. Why is the goal 7? Well, we did that trial. We tried to get people down to normal ranges, and what happened was they had hypoglycemic events. Yes, hyperglycemia takes your kidneys, takes your eyes, takes your limbs, but hypoglycemia kills you. It is better to have slightly elevated blood sugar for long periods of time than it is to have acutely low blood sugar, which leads to people's death. So, to get the benefits of glucose control, that is reduced micro and macrovascular complications, get the A1C less than 7. But to avoid death from hypoglycemia, allow it to be in the 6s. And then, of course, there's going to be something that you need to watch out for, right? So the things that diabetes goes after, and this is just have to know it, is going to be the eyes, the kidneys, and the feet. And that is retinopathy, nephropathy, and neuropathy. Diabetes causes microvascular complications everywhere. These patients are at risk for coronary artery disease, they're at risk for peripheral vascular disease, but most importantly, they're going to be at risk for retinopathy, nephropathy, and neuropathy, and they need an annual screen for each of these. For the annual screen for retinopathy, they need a retinal exam. And if they developed diabetic retinopathy, then you need to use laser ablation to cure it. Nephropathy, they need a urinalysis, specifically a microalbumin to creatinine ratio. If they end up having proteinuria, they need an ACE inhibitor. In the neuropathy, they need a monofilament screen. And if they have positive neuropathy, they can be treated with medications like gabapentin, which make their neuropathy feel better. But they also need then to be very cautious. If you have neuropathy, you can't feel that your shoes are too tight, and you might develop an ulcer. You don't realize you stepped on a tack, and then you get a wound. So patients need to look at their feet constantly. And once the damage is done, it's pretty much done. What you want to do is try to prevent progression of the disease by controlling the A1C and continuing to screen them. Okay, this first diabetes lecture I know has a lot. We focused primarily on the diagnosis, memorize the cutoffs for each of the tests, recognizing that type 1 diabetes has a little something extra, which is you should test for antibodies, remembering now that type 1 is autoimmune destruction, not insulin dependent, not juvenile. Treat prediabetes with lifestyle and metformin. The outpatient management of diabetes is lifestyle and metformin unless they can't use metformin. Add a second agent if their A1C is not at goal after 3 months. Add insulin if their A1C is not at goal after 3 months of the second agent. If their A1C is greater than 9 at diagnosis, start at insulins. Here are the medication classes. Scary? And then don't forget about every 3 months A1C, every year, retinal exam, urinalysis, monofilament examination. That is outpatient diabetes.